current evidence around intensive care and also national guidelines now are starting to identify that early rehabilitation for patients on intensive care units improves their outcomes. So we decided to do a pilot of occupational therapy input into critical care to look at whether that would have a benefit for patients and improve their rehab potential on the unit, and then also going forwards when they transfer to the wards.
At the time, John was ventilated, had a trachea in, and wasn't communicating at that point. So as we started working with him, it was to look at his muscle function, try and stimulate him by using his upper limbs to help wash himself and get some normal movement going, a normal activity which would hopefully bring him round and enable him to interact more with us and interact in his activities whilst on ITU. So throughout the process on ITU, we looked at how his psychological state was. So we looked at what was worrying him, and once we'd identified what was worrying him, we resolved that by getting, one instance was he wasn't aware of what had happened, so we asked Nicky to come in and speak to him about his journey as it had been to that point. Also from there, he wasn't sure when he woke up in the morning where he was and what day it was, so there was a clock opposite him, so we utilised the clock to enable him to identify what day it was, what time it was, so that he could do that without having to ask somebody, which he wasn't able to do at that point. From there we looked at his upper limb activity. He had had a stroke and one of his limbs was quite a bit weaker than the other, so we looked at integrating his limb using exercise sheets, which we discussed with the family, so that the family could work with John in their time with him, so that they felt that they were part of his treatment as well, and it gave them a focus whilst they were there and made them feel useful to him as well. From this point, John was progressing and becoming quite a bit more alert. He was sitting out in a chair for short periods but was struggling with that, so we adjusted the pattern of treatment so that a lot of his therapy was done on the bed because he did tire easily. And we got to the point within a few weeks where John was much more medically stable. The trachea had been removed, so he was communicating much better with us and expressing his views and goals of what he wanted to do. And by then we were actually sitting in bed and he was washing his face and washing his upper body, and this was before he left ITU. So from that was a big step forward for patients, that they were taking control of their own care and having some role in it rather than being nurse-led.
HDU helped me an awful lot, because as I went in there I could barely do things for myself, but as I came out of there to go to the stroke ward, I was well able to do things, sitting up and doing things. I was encouraged to wash myself on HDU. I felt it was brilliant to be able to do it on your own, than having other people to do it for you. On HDU I was listened to very carefully, and every issue that we had there was dealt with.
And by the time he got to the stroke ward, from my perspective, I felt that he was ready to engage in rehab, because he'd already been engaged from the minute he became alert enough to be. He knew what he needed to do to progress himself and work with the therapist for that, and I do hope and I do believe that that had a much more positive impact on his rehab from the stroke unit.
To start rehabilitation on the stroke unit, I was up for it. I was scared and that, but I was fully ready for anything that we had to do and that. They had prepared me well, they had explained everything to me.
Because we've not had OT input before, often patients' rehab was around physical things like trying to sit up, trying to stand and move, and less about patients' function. So actually having Helen with us to do the pilot, particularly with John, looking at function, looking at also the psychological part of it as well, because that's a big role within OT, I feel just made a huge difference to the patients that we managed to treat, John being one of them, to try and progress them and make them more ready to do rehab once they hit the ward.
From the psychological point of view, John was, from a standardised assessment that we used, John was deemed at risk of having psychological risk from being in ITU, which is something that patients regularly have from the traumatic experiences they've been through. But actually by the time he left ITU, we repeated the same questionnaire, and John was actually within normal range, and we'd addressed all his concerns at that time. So I think, again, that was another factor that helps him move forward more in his rehab at that time.
To give a message to the team, I would like to thank them for everything, because it's as of them that I'm here today. And I would really like to thank Anna, Melissa, Helen and Nikki, because they're the only ones I can remember from there.